Thanks very much, Dougal. So I'm really pleased to be here. I haven't been to one of the DCP meetings for quite a while, but I was very pleased to see intellectual disability forming the backbone of this meeting. The other reason I'm particularly pleased to be here is it gives me a chance to catch up with my PhD supervisor, Glyn Murphy, who's down here. It's really lovely to see her, but particularly because she'll be receiving the MB Shapiro Award later on. So I thought, was terrific, been invited to do the keynote at the DCP. But still, after all these years, sort of trailing awake. So that's great, and I'm really pleased to be here for that. So it's sort of deliberately provocative in a way of taking what for us are commonly used terms and concepts and saying, do they serve us well? And I'm not necessarily coming down on one side of the argument or the other, but I just want to raise some of the issues around the use of these two terms and concepts and explore whether they serve us as well as other approaches and how we sort of may integrate those. And I think it's really important when, as a field emerges, that you occasionally take a step back and say, well, what are our organising principles? And I tried to come up with this sort of, I was on the train last night coming up to York, and I was trying to say, well, what is an organising principle? And if you open your programme, you'll see the organising principles, the way the streams are divided, symposia and so on. But I was trying to just capture the idea that whether we do this deliberately or not, organising principles emerge, and they emerge and are translated into how we might deliver services, policy documents we might produce, how we organise training, how we organise research, disseminate information, and so on. And the two principles that I think are interesting and challenging behaviour and intellectual disability in that respect. So I'm just going to explore those, but particularly with an eye to contemporary and emerging research and whether they take us a bit further forward than those concepts do. So you've probably seen this definition earlier on today. But the purpose of this definition, when we moved away from terms like behaviour disorder and behaviour problem, we were doing a number of things, or a number of things were happening. We were trying to minimise pathology and difference by saying that these are really understandable, typical behaviours, if you like, given the environments and the circumstances that people find themselves in. We were locating cause and thus responsibility for change in both the macro and micro environment. So we were taking the behaviour out of the person, if you like, and we were emphasising function and meaning. And that's very evident in some of the quotations used in the BPS document in 2007, I think it was. And so that was the purpose of this definition. And the purpose and how this has emerged as an organising principle, because you can see policy documents on it, you can see services arranged around it, and then we can just start to explore the implications of that, I think. So if we just take that definition and we say, well, what behaviours might be included as a result of that definition, then you can see remarkable diversity. You can see anything from headbanging in a child with a very profound intellectual disability right through to excessive alcohol intake in someone with a mild intellectual disability. All of these behaviours could come under the banner of challenging behaviour. And so the point, I think, that arises from this for me is that once we use that term, are we diluting what we know about those individual behaviours? And that's what I want to explore. So just to pursue that, to show how loose these boundaries are and loose the definition is. If you then look at the last 10 years of JARID and JIDR, the two UK intellectual disability journals, and look at what is used to measure challenging behaviour, you'll see the aberrant behaviour checklist. Then you look at the 5 factors, then you look at the individual items, and these items, if you score highly on these, you have a higher challenging behaviour score as interpreted by the authors. So you can see now that you've got a number of different, even more diverse behaviours in there, some of which we wouldn't really recognise as wanting to be encapsulated within that term if it was serving us well. And I'm aware that there's a group has formed under Glyn Murphy's Glyn Murphy as chair to produce NICE guidelines on challenging behaviour. And so one thing I did is I just went to the NICE website and picked off the first, this is going back to January 2004, and just picked up the list of the first guidelines that came out of NICE. And I think what's interesting when you look here, this was quite by chance, but eating disorders, self-harm, violence, OCD, post-traumatic stress disorder, depression in children and young people. So if I just flip back to, you can see some of these behaviours actually, for people of typical development, have their own set of recommendations. They are not brought together. And so in a way, one has to say, well, if we start to bundle those up for people with intellectual disability within the guidelines, is that guideline going to be equivalent in specificity and sensitivity to the guidelines that are produced for people of typical development? And that's one of the points that I want to pursue, if you like, that this difference is potentially detrimental, I think. So I'm going to just think, so that was a fairly easy argument to make, I think, because I'm taking extremes of the behaviour. If you take, excessive drinking in someone with mild intellectual disability, headbanging in someone with a profound disability, we can easily see that they don't hang together well. But let's take the behaviours that we all kind of use the term challenging behaviour for. So I'm going to take self-injury, stereotype behaviour, aggression, that we might say, well, yeah, they would normally get bundled up under that term. But I just want to explore and then explore the implications of differences between those forms of behaviour. So if we start to break the behaviours down and stipulate what these behaviours are by name and form rather than impact on the environment or the person, for example, do we see differences? And critically, are those differences important? Prevalence varies. So if you take self-injury and aggression, you will typically get a prevalence figure for aggression that is double that of self-injury. So if you look across all the literature, that's pretty much uniform. So these are data from nearly 1,000 children in Birmingham. And we found exactly that the prevalence of self-injury is about half that of aggression. You may say, well, so what? That's obviously going to be the case. There'll be variability in prevalence. But I think the point is that if we adopt, for example, an exclusively operant explanation, then we would expect the nature of the behaviour to be randomly distributed because all of the effect is in the environment. And we don't see that. We do see systematic differences between those behaviours. We can pursue that argument within particular genetic syndromes. And I'm just going to mention this and come back to it in more detail later on. But here you have a group of people with heterogeneous cause of intellectual disability, then people with Angelman syndrome, Creder-Shack, Cornelia de Lange, Fragile X, Prader-Willi, Lowe, and Smith-Magenis. So these are all genetic disorders associated with intellectual disability. And if you look at the prevalence of self-injury in those groups, it varies dramatically. And so in Cornelia de Lange, you are 6.5 times more likely to show self-injury than if you just have an intellectual disability, if you like. Now that's important for a number of reasons, but more importantly is that these behaviours within given groups and by implication within individuals dissociate. So whilst in Cornelia de Lange syndrome you're more likely to show self-injury than a heterogeneous group, that is not true for aggression. And in Angelman syndrome, the reverse is true. So these behaviours dissociate within individual syndromes. And that's an empirical observation, but what one might think is behind that, of course, is some kind of causal mechanism that is presumably contributed by the person rather than the environment, which we would guess is randomly distributed across those groups. So that seems to me quite an important difference that we would miss if we lump those behaviours together. The second, this is a little bit speculative, and Kate Woodcock will speak a bit more about this in the symposium afterwards, but the nature of the behaviour differs as well in some very important ways. And you'd have seen when I put up the aberrant behaviour checklist, they included a term temper tantrum, which is always rather a belittling term, I think. But nevertheless, temperoutburst is something that we as clinicians would commonly see. And its nature, I think, is very different from that of operant maintained aggression or self-injury, where there are episodes of behaviour not necessarily associated with high levels of arousal and obvious emotional distress that maybe appear for a prolonged period of time. This is a poster by a young woman with Prader-Willi syndrome, and she was describing what happens to her. So temperoutbursts are very, very common in children and young adults with Prader-Willi syndrome. And people would describe them a bit like this author's describing her experience of this change in her emotional state as this temper becomes, as that emerges, as that temper outburst progresses. Now, the point about this is that it may qualitatively differ from other behaviours which would come under the same banner, but are simply operant behaviours not associated with emotional distress. And within our team, Penny Tunnicliffe, I don't expect you to get the detail from this, it's just to show you the design, 15 interviews with parents of children and young adults with Prader-Willi syndrome, and then interviewing what's the nature of that temper outburst, what happens in that temper outburst. And so being able to describe some initial distress turning into difficult behaviours, destruction, self-injury, verbal aggression, then turning into anger, and then the critical bit is at the end. And what she described in nearly everybody was remorse, was people apologising profusely about the behaviour and saying things like, I don't know what happened. And interestingly, in two other genetic disorders, septo-optic dysplasia and Smith-Magenis syndrome, you see a very, very similar presentation of an emotional outburst that lasts for a very long time, high levels of physiological arousal. So Kate Woodcock measured heart rate in people under these conditions whilst controlling for activity and showed very, very high levels of physical arousal. You can see facial flushing. But at the end of it, again in Smith-Magenis syndrome and septo-optic dysplasia, you see this profound apology and people saying, I don't know what happened. And the importance there is that we may assume that those behaviours, it may be the case that those behaviours are not operants in the way that we would typically think of them, and there is some more autonomic nervous system involvement, and consequently trying to curtail or change these behaviours with contingencies, with reinforcing contingencies, may not be effective. So I think that's another way in which different behaviours are critically important. This is a little bit more speculative, but it's a line of research we've been running for a while now, and I did want to bring it to this audience, and it's about the role of pain and discomfort, particularly in non-communicating children, in challenging behaviour. The research literature is small. That's because we all back away from this problem because you've ultimately got the validity problem. So I go and see my colleague in the psychology department. How do we know someone's in pain? You ask them. That's the outcome. So for non-communicating children with profound intellectual disability, we have to address this. And we've done it in a number of ways. There are a number of different measures you can use. But we felt for a long while that pain and discomfort is critical in causing some behavioural change, and in particular forms of behaviour. And I just want to develop the argument here that causes of behaviours may differ. So the syndrome of interest here is tuberose sclerosis complex. So we've taken this because you often have tuberose growths in the brain and the kidneys, so you get headaches and you get flank pain. So we know these children are at very high risk. There's also, in about half of the children and adults, severe intellectual disability, so they're carrying risk markers for self-injury and aggression. And what you see here is the NCCPC, non-communicating child pain checklist, and that the score there would indicate higher pain, and this is comparing a group with self-injury and no self-injury, and you can see the difference. Now you might say, well, clearly you feel more pain if you self-injure, but the types of condition that are associated with tuberous sclerosis complex are not associated with the self-injury, if you see what I mean. You often get this flank pain associated with pain from the kidneys. So the point is there, you've got an association between pain and self-injury. We can ask another question. So for example, in children and adults with autism spectrum disorders, what's the relative risk of self-injury given that you have a health problem? And in children, that relative risk, the lower confidence interval exceeds 1. So in other words, health conditions are associated with self-injury. You might make the argument of causal direction again, but again, it's middle ear infections and very importantly, gastrointestinal disorders in children and adults with autism spectrum disorder that seem associated with self-injury. So we've got this, it's kind of, different forms of evidence coming together. There's obvious acid tests for this, removing the pain, does the behaviour go away? And that's what we're working towards now. But I just want to show you this. So sorry, it's a bit of a fussy slide, but this is whether or not you're showing a number of signs of gastroesophageal disorder. So we're looking at reflux, constipation, those kinds of problems. Showing it, not showing it, whether the behaviour is present, not. People with Cri-du-Chat syndrome, that's a deletion on chromosome 5, and people with autism spectrum disorder. Okay, so you see that if aggression is present, self-injury is present, you're more likely to show, if gastrointestinal disorder is there, you're more likely to show aggression and self-injury. But what I want you to look at is the effect size here. So the effect size is much, I should have put relative risk up, but the effect size there is much stronger for self-injury than it is for aggression, and in fact significance disappears in the CDC group. So the point we're making there is that alongside a couple of other studies, we're showing that actually pain may be more likely to be associated with self-injurious behaviour than other behaviours. So the point there is that if we take the form of the behaviour as a starting point, it then makes us have it helps us to have different hypotheses and just shuffle the pack differently in terms of assessment procedures, particularly if they're going to be intrusive. This is a slightly convoluted argument, but stay with me because I do think it's worth it. It's about correlates of behaviours. So this is a study of PhD student Louise Handley in our group who looked at over 100 children recruited in child development centres in Birmingham. And these are children under 12, so we're trying to pin down some of the risk markers for self-injury and aggression. And what's important about this is that there are different correlates, behavioural correlates for aggression than self-injury. And we've shown this now repeatedly in a number of studies, and what you see is overactivity and impulsivity predict aggression, but self-injury is predicted by repetitive behaviour. And when I say predicted there, I mean within a regression analysis. And so we've shown this a number of times that these background behaviours are correlated with different outcome behaviours. And that might be important for cause, and I can come back to that at some point. But simply at a pragmatic, empirical level, it's important for a different reason. And this is the work of Louise Davies, a PhD student in our team, who saw around 400 children in Birmingham, and then she saw them 15 months later. And she looked at self-injury and aggression at time 1 and at time 2, and she looked at these behavioural markers at time 1. And then we looked at onset, which children went on to start to show that behaviour, incidence, not persistence. And what's important here is that if at time 1 you were showing these restrictive repetitive behaviours, then 15 months later you're about 2.5 times more likely to be showing self-injury. But but that wasn't true for aggression. It does not predict the future development of aggression, whereas here, overactivity, impulsivity predicts the presence of aggression in 15 months' time, but not self-injury. So just at an empirical level, regardless of the models that we might think of behind that, and there are a number of kind of theories you can think of that can help us understand that, just in predicting onset, that's important. Now, we can only do that if we'd have lumped those behaviours together. We wouldn't have got that if we'd have not differentiated the forms of behaviour. I'm not sure about this, and I think the NICE review is really important in this respect. But I haven't looked at the literature across different behaviours for a number of years. But if I just search in JABA, which is where we'd find a lot of the hard end operant evidence, you find that the strength of evidence for different forms of behaviour varies significantly, but as evidenced by the papers published on those topics. So my guess is that you would see a much stronger, a more precise evidence base for something like self-injury than you would for stereotype behaviour or temper tantrums, simply because there isn't the size of evidence base. The problem there, I think, is if we bring those behaviours together and comment on the evidence base, will we dilute the evidence for some behaviours because we're bringing other behaviours in? So I think there's an important question there to be asked about whether strength of evidence varies across the behaviours that we bring together. So let me just pause there, because I've taken the idea of challenging behaviour, something that we readily accept and has been very useful to us. I don't wish to minimise that. It's been very useful to us as a profession in engaging with the things that need to be done around that behaviour. But I wonder whether, as an organising principle, if we adhere to that without qualification, that we then start to dilute our understanding of that behaviour. And I want to now try to mount a similar argument around severity of intellectual disability. And this one's slightly more, it's not really questioning the value of severity of intellectual disability as an organising principle, but it's saying behind that there might be another organising principle that does something very, very useful for us. So I've taken the definition of severity of intellectual disability, again from a BPS document, and you can see that one of the distinctions that is drawn is about degree of impairment, and then there are qualifiers regarding adaptive behaviour and so on, and level of support required. So it's still, I think, a very good document in that respect, and I accept there'll be, these borders are arbitrary and so on. But I want to ask the question of whether there is another organising principle that we might think of that might give us a better quality of information in a number of different ways. Now, I do expect you to put all these down, write these down. So these are just some of the genetic syndromes that are associated with intellectual disability. And some of the names you'll know: Down syndrome, Fragile X syndrome, comparatively common genetic disorders, and many of them you won't. The last estimate was there was something like 1,700 individual genetic disorders associated with intellectual disability. And the question that sort of immediately arises, so what? Does that matter? Does it matter? Does cause of intellectual disability matter at all? And I want to make the argument that it does something for us as an organising principle that's quite important. So it tells us about difference in the probability of behaviours. It says something about the probability of psychiatric diagnosis, but also helps undermine the kind of utility of that for people with disability. And it helps us understand cognitive impairments over and above that of intellectual disability. And I think that's a really important point, as well as being able to build models of behaviour and ultimately understand causes. I'll go back to this graph because the behaviour profile differs. So if we were thinking about early intervention, targeted, risk-related early intervention, just from these data, we can, to some extent, predict which children will develop certain forms of behavioural difficulty in the future. And these data are really quite robust across studies. So it's very clear that knowing that a child has a particular genetic syndrome allows us to know something about the probability of behaviours of clinical significance that would be deemed to be challenging. This will be a bit of a digression, but I think there's an important point to be made here. So equally, you can see that across all of these genetic syndromes, the probability or the percentage of people who are scoring above cutoff for autism or autism spectrum disorder varies dramatically. So in people with Down syndrome, and this is again replicated across a number of studies, it's around 8% of people would attract a diagnosis of autism. Whereas in Fragile X syndrome, Cornelia de Lange, it's about 50%. So clearly, as you move across this graph, the probability is significantly increasing. 8% sounds low, but of course that's much, much higher than we should expect by chance. There's still something, still some kind of association there. So a point I'm making here is that if you know someone has a genetic syndrome, then you know the probability that they may develop behaviours that may trip the diagnosis for autism. The question of whether or not this is autism is one for another day. Well, no, let's do it today because I think it is quite interesting. So one question what people do say is, well, that's all about degree of intellectual disability. If you've got a greater degree of intellectual disability, this has been demonstrated, a number of studies by Lorna Wing, Chris Gilberg, you are likely to have, more likely to have an autism spectrum disorder. So let's control for that. So in this study, we control between people with Cornelia de Lange syndrome and Creda-Schaff syndrome, and you get much higher levels of autism spectrum phenomenology in Cornelia de Lange than Creda-Schaff. Even though you've controlled on BPVS, so that's receptive, you control on adaptive behaviour, and you control for a speech impairment, because both groups will have a speech impairment. So you control all of these things, and you still get this difference. And at the bottom, we've controlled for age, gender, degree of disability, mobility, and you still get the difference between Cornelia de Lange and a contrast group. The other argument is that in some syndromes, for example, Creda-Schaff, where the degree of disability is greater than, for example, Fragile X syndrome, you don't necessarily get a higher prevalence of autism. So clearly something else is happening there. And here comes a digression, because I think it's important. So just copy these down while I'm speaking, but this just shows you the idea here is that what the behaviours that go to make up that diagnosis of autism differ across the syndromes. So what you're looking at is 20 different types of repetitive behaviour. So in each star graph, you can see 20 different types. So in the bottom corner here, this is people with autism as a sort of reference group. And then you can look at all the different syndromes and say, to what extent are you similar in terms of the profile of behaviours? Are they stereotype behaviours, adherence to routine, lining up, attachment to objects, or whatever it might be? And there you can see Cornelia de Lange syndrome, and you immediately see a different pattern. And it doesn't sort of matter what the pattern is to some extent. What matters is that it is a different pattern. So the behaviours that are contributing to tripping the diagnosis of autism are different, and that's important. Just as an aside, you also, in some groups, Prader-Willi syndrome, here in Creda-Schaff syndrome, you see these very spiky patterns. So what you see is highly specific repetitive behaviours, but many of the others that are in the autism group are not there. And that's really quite interesting, because it could still trip autism diagnosis, if you like, but there are very few behaviours, and there isn't a generalised behaviour. And I'm showing those because I'll come back to Prader-Willi syndrome in a second. So the point we've got to is saying, well, there's difference in autism, but even if we say, okay, let's control for degree of disability, let's control for autism ADOS score. So two groups with the same ADOS score, both tripping the diagnosis, and compare people with so-called idiopathic autism with people with Cornelia de Lange syndrome, you get an uneven profile. So here, if you can see these differences here, this is ADOS algorithm items. You can see here the that's the ASD group are scoring significantly higher than the CDLS group on these two items. It's use of gestures and eye contact. So the CDLS group are not as impaired on those particular items as the autism group. So the important point here is that, in a way, knowing something about the genetic syndrome may tell you about a risk for autism, but actually once you dig down a little bit further, you start to see a particular profile within that diagnosis, or a particular profile of behaviours that are very different from autism spectrum disorder and might have other sorts of differences. And so it's a real debate at the moment within the behavioural phenotype groups of saying, well, is it useful to have a diagnosis of autism? And we say you can either be a pragmatist or a purist. Pragmatically, yes, because it might access you services, it might access you support that helps you. If you're a purist, probably not, but because there are some subtle differences within there that we need to know about. So that's a bit of a digression. But the point I wanted to make there is that it can look like the syndrome tells you something about a psychiatric diagnosis, but when you go a bit further, it tells you something much more interesting, and it erodes that boundaries of psychiatric diagnosis and shows it's a bit more flexible. When I go to syndrome support groups and I meet parents, we're often meeting parents of very, very young babies, of children under the age of 2, for example. And you know when they come to these meetings that one of the big questions they have is, what does the future hold? What will happen in the future? And that's the reason that they come to the meeting. And it's a very difficult time for them because, of course, they will see children who look physically, facially, very, very similar to their own child because of the facial dysmorphology. And as they come through the door, they're almost looking into the future. One of the interesting things as you follow groups up over time or you look with age is that some of the behavioural phenomenology differs in its trajectory across different syndromes. So if we take the 2 high-risk groups for autism spectrum disorder, Cornelia de Lange syndrome and Fragile X syndrome, you can see here a different trajectory between the under 16s and over 16s. The Fragile X group, the autism score is going down, the Cornelia de Lange is going up. It changes a bit later on, but nevertheless there's a different trajectory. And you can show this in a number of different syndromes for a number of different problems. Increase in anxiety in Williams syndrome, for example, and of course we've always known the increased risk of dementia in people with Down syndrome. So I just pause there because what I've done to this point is talk about behavioural differences. And I just want to say something now about cognitive differences in people with different genetic syndromes and their importance. So what I want to make the argument that this is really the intellectual disability bit, if you like, that if you know someone that has a genetic disorder, then you will know something about their cognitive profile that is different over and above their degree of intellectual disability. And this is Kate Woodcock's PhD work, and what she was looking at was the repetitive questioning and adherence to routine that you see in Prader-Willi syndrome, that if you disrupt this, you can often see the temperoutbursts. But at this point, what she's looking at is there a cognitive profile in Prader-Willi syndrome that could account for adherence to routine and repetitive behaviour, repetitive questioning. And what she found is that if she got the children to engage in a switching task, a Simon switching task, where you have to switch your attention from one aspect of a stimulus to another, and you record reaction time. If you match the children with Prader-Willi syndrome, typically developing children, what you find is that the children with Prader-Willi syndrome take a lot longer to switch. There's a greater load on them to switch attention. Now that was a really exciting finding because that is a problem over and above that of intellectual disability. But more interesting was her finding that if you correlate reaction time on that lab task with a day-to-day measure of adherence to routine and repetitive question, they correlate. So if you are longer reaction time in the lab, you are showing more repetitive questioning and greater adherence to routine on a day-to-day basis. So here we had a cognitive explanation, if you like, a cognitive behavioural explanation of a behaviour of significance for people with Prader-Willi syndrome. And then Kate's been supervising another PhD student who's been trying to help people with Prader-Willi syndrome predict change in routine such that they're able to, if you like, garner resources to deal with that in the future. But that intervention critically depends on understanding that particular cognitive profile. Just as an aside, because someone spoke about this before lunch, about attributions and locus of control, it's really interesting. One of the interesting things is that in the literature, people with Prader-Willi syndrome used to be described as obstinate and stubborn. And so that is very value-laden. That means you can do something, but you won't do it. But what Kate was showing here was actually not being able to do that thing is not a choice. this is very, very difficult. This is much more difficult for that person to switch than anybody else. And when you discuss that with parents, they say, I told you so. But other people will also have that shift in attribution, that suddenly the person is not being willful. And those dimensions of attribution, the global, internal, stable, uncontrollable, shift. And that, I think, was a really important lesson for us about how important it was simply giving that information. I'll show you one more example. This is syndrome of interest here, is Rubinstein-Tabie syndrome. And again, you see high levels of repetitive questioning. And the question posed both by Laurie Powis and Jane Waite, two PhD students who worked on this project for 3 years, was, in this case, what accounts for the repetitive questioning. And this is a very troublesome behaviour, both for the people themselves, but also for parents and carers. Forgive all the sums up there, but what was very exciting about this was what Jane was able to show is that if you do a conflict inhibition task, so this is the bear-dragon task, so you have to do what the good bear says, but not what the naughty dragon says. I'm sorry about the negative stereotyping of the dragon there, but that's how it is. And what happens is that the repetitive questioning, again on a day-to-day basis, was predicted or correlated with response to the naughty dragon. That if you responded to the naughty dragon more than you should have, that would predict your repetitive questioning. And the idea that, and even if you then put receptive language and degree of intellectual disability into the correlation, the effect, the association remains. So again, what's important there is understanding that from the person who has Rubinstein-Tabie syndrome's point of view, that they probably find it very, very difficult to inhibit that behaviour. It's not something they can easily do. The point I was trying to make, I know that feels like a bit of a digression, is that once we understand those cognitive differences, it gives parents and carers a different perspective, gives people themselves a different perspective, and helps us understand, build good cognitive behavioural models of these perhaps. I'll just finish on causes of behaviour. I've already mentioned Cornelia de Lange syndrome, so if you are clinicians, if you've met someone with Cornelia de Lange, it's very likely that they may be showing very severe self-injurious behaviour. That was typically the presentation. And this, we, over the years, have sort of uncovered the relationship between that and gastroesophageal reflux. Most children will have awful reflux, significant pain, and the pain is there. We see high levels. That was our clinical observation. And then that led us to think about, well, so would we then compare that to a different syndrome, in this case Angelman syndrome, where you see excessive sociability and high levels of aggression? And our question became, well, could it be that the cause of difficult behaviour in Cornelia de Lange syndrome would be pain, and in Angelman syndrome, because there's such strong motivation for social contact, will be aggression, because one consequence of the aggression would be social reinforcement. We demonstrated that in analogue studies, but also in using something like the QABF, where we found pretty much what we predicted. So you've got another group of Cri du Chat in the middle there. But here you can see that genetic cause matters. And it helps you shuffle the pack in terms of intervention, as well as demonstrating a principle. So pain was much more common in Cornelia de Lange syndrome. Here, attention maintenance was much more common in Angelman syndrome. And Paul Langthorne and Peter McGill at Tizard Centre did some excellent work around Fragile X syndrome and Smith-Magenis, showing very similar distinctions. So this means we're building now a database that shows us about different probabilities of cause within the different behaviours. So what I hope I've done is sort of take the idea of an organising principle as applied to challenging behaviour as it's currently used, and severity of intellectual disability, and show that there are sort of some pitfalls of using that as an organising principle without reflecting on what that principle enshrines, what it includes, and that going beyond that might give us better organising principles. And I just want to explore that in terms of this kind of question. Does this matter? Does it matter for us as clinicians or strategically? The first thing to say is existing concepts are clearly useful. I wouldn't have used them throughout the talk. I've been using them. And clearly, you've heard today that sometimes it's useful to use these terms, but we must be aware of the pros and cons. So some benefits of having a more refined organising principles, both of behaviour and perhaps cause of intellectual disability, is I do think we get better, more precise, more complex, but more precise causal models that explain more of the variance in behaviours of interest than we could previously do, and that has to be the acid test. The second thing is it does help us, in both cases, I've shown that it's helped us to be able to predict the future. So this is, I know you can't see the detail, but what we've done, and it's an article we've just got under review, we have tried to list risk markers for self-injury. So the wonderful early intervention presentations that we heard, we might be able to target these groups based on these risk markers, knowing that they're at extremely high risk for the development of these behaviours. And on the right-hand side, we can sort of quantify this risk. And on the left is degree of intellectual disability, so it is a useful concept under some circumstances, autism, genetic syndromes, repetitive behaviour and health problems. This is helping us to make maybe helping us to make a prediction. We're testing that now. It could make our assessment more efficient if we know something about the behaviours. And again, I know you can't see this, but this is a protocol that we are now trialling for the assessment of self-injury. So we have 3 areas. We have pain and discomfort, then we have a learned behaviour, and then we've got a notion of behaviour dysregulation, which is a little bit contentious, but it helps us explain some the association with impulsivity. It helps us explain the association with repetitive behaviour and behaviours like self-restraint, which are very difficult to explain. And then you have a number of phenomena that you would observe that would give you evidence for each of these, and then a number of tasks that you would carry out in assessment. Now, the point about this is that you would not necessarily say, you know, that child with that syndrome is showing that behaviour, I'm going to intervene like this. But you would say, I think we should shuffle the pack. I think we should be doing much more on this to a greater degree of intrusiveness than would otherwise be the case. So we're really going to go after pain, or we're pretty sure that that is unlikely to be the case. We might then have more undiluted evidence, if you like. So if there is stronger evidence around something like self-injury than other behaviours, the evidence we can put forward might be stronger than if we bind that evidence up with other behaviours. And finally, I think this is bringing the 2 ideas together with all the problems that enshrines. It's about giving targeted, context-sensitive advice and information. Last fussy graph, I promise. But the point is that when one of these behaviours presents in a child with a particular syndrome, there is the context of the other behaviours that are associated with that syndrome that need to be taken into account. And so the sorts of interventions and the context for that intervention is going to be very, very different depending on that syndrome. And Dawn Adams will show later on differences across groups in parental stress predicted by syndrome, for example. But just to show you one example here, so you see sleep disorder, both in Angelman and Prader-Willi syndrome, but you see less motivation for social contact in Prader-Willi syndrome than Angelman syndrome. So we put actigraphs on children with Prader-Willi syndrome and Angelman syndrome, and we put actigraphs on their parents. And what we're working out is who gets up and when. So you can do it at sort of lag-based time analysis. The answer is that both groups wake the same amount. Children with Prader-Willi syndrome wake because of a sleep apnea. Children with Angelman syndrome are short sleepers. But the parents in the Angelman's group were much more likely to be awake when their child was awake than the parents of the child with Prader-Willi syndrome. There was something about the social motivation that made that sleep that interaction between aspects of the phenotype that drove that. And then the issue is that one of the big predictors of stress in parents with intellectual disability is actually sleep disorder in the children. That's very, very significant. So now, when you're trying to deal with any of these behaviours, this context in these two groups is absolutely critical, because unless you've got on top of the sleep disorder, the parents are finding it very, very difficult to deal with other behaviours. So I'm wondering there whether it sort of begs the question of, should we start to think about syndrome-related behaviour or syndrome-sensitive interventions that package up a number of different supportive aspects for parents? And that probably is very, very far away from a conceptualisation of challenging behaviour, if you like. The last problem, I think, is everyone will say these syndromes are rare, and that's true, but they're not uncommon. So if we do some sums, and Kate Woodcock did these for us years ago, and we say, well, about 50% of people with severe intellectual disability will have a genetic disorder, about 13% with a mild moderate, and so on, you can do these sums, and you come up with these figures of around 300,000 people in the UK. So these individual rare syndromes, they are rare, but the overall numbers. And I think we probably should not be daunted or constrained by rarity. I think parents are being failed if we do not try and solve that problem. Just because a child has a rare disorder, that they don't have the same level of information. This number is increasing, of course, the proportion's increasing with the project at the Sanger Institute, identifying more and more. And that last thing about the amount and organisation of information. So Glyn's task in chairing the committee on the NICE guidelines, how do you, if you took these ideas on board, how would you organise all of that information? Are you saying we'd have 30 recommendations and then they'd be different for each syndrome group? Suddenly you think, well, this is just overwhelming. So clearly we're not going to be able to do that. But when you think about those sorts of issues, the interweb is absolutely designed for this. And so we're about to build over the next year with funding from ESRC a website called FIND, which stands for Further Information on Neurogenetic Disorders. We didn't think that up. It cost us $5,000 from the web designers for that, but well worth the money. FIND, and what we will do is have those two dimensions of the syndrome and then the behaviours and the different causes, and hopefully a guided pathway through that for strategic kind of levels of intervention that can take both parents and professionals through that, picking up the information on the genetic disorders that's relevant and picking up the information on the behaviour that's relevant. So I think there are various ways in which services may find it very difficult to respond to both of these issues, but actually maybe there are other organisations and other vehicles for delivery of information and services that we should be considering. And one of those, I think, is the syndrome groups themselves. A lot of them are very active, very well organised. And in Norway, they are actually funded by the government to organise some of their own services, interestingly. Much smaller population, only 5 million people, but they do it very, very effectively. So I'm going to stop there and just thank all of these people who do all of the work. And they're really wonderful people. The projects that we talk of, when I just talk flippantly about a functional analysis of aggression of children in Angelman syndrome, it means that people were losing hair on a daily basis, and it wasn't worry either, it was actually being with the children. So they do some terrific work, and thanks very much to our funders, and thank you for your attention just after lunch. Thank you.